Cryptophthalmos. What is cryptophthalmos? The word cryptophthalmos is derived from Greek, which means hidden eye. It is a rare congenital anomaly in which the skin from the forehead continues over the globe onto the cheek, and there is no separation of eyelids and no eyelashes. It was first described by Zehender and Mans in 1872. It is often associated with other congenital anomalies: syndactyly, urogenital defects, diencephalic or Fraser syndrome. The other features are absence of eyebrow, tongue of hair coming down, nasal deformity. See a picture of a cryptophthalmos where the skin of the forehead is continuous over the eyes onto the cheek without differentiation into eyelids. The globe under the skin projects as an elevation where some movement are discernible with movement of the opposite eye. Sometimes patient is able to perceive light when a flash of light is projected on it. The histopathology of the globe shows the anterior segment to be disorganized. The most likely mode of inheritance is autosomal recessive. Here you see a common grandfather with cousins, both having cryptophthalmos. Another example of a brother and sister, both having cryptophthalmos. Three sisters. The youngest had total cryptophthalmos both sides. The next sister had left-sided total cryptophthalmos. The first sister had no anomaly. The girl with the total cryptophthalmos both sides was well trained in Braille and has completed 10th standard. She is planning to do her +2 also. A CT scan of a bilateral cryptophthalmos which shows intraocular calcification. The suggestive causative factors are many. This case shows an amniotic band possibly which may have produced the anomaly. Deficiency of vitamin A and retinoids during gestation, genetically induced abnormality, amniotic bands and inflammation. Total or complete cryptophthalmos, as you can see in this child, forehead skin continues over the globe onto the cheek. Partial or incomplete cryptophthalmos, the skin fold covers the medial aspect of the palpebral fissure, with the lateral lid structures being small with foreshortened upper and lower fornices. The eye may be cystic or absent. Imaging shows a shrunken orbit, complete cryptophthalmos, principles of reconstruction, reconstruction of both eyelids. One needs to make anterior lamella and posterior lamella, reconstruction of socket to fit an eye shell. The socket has to have a lining of mucosa, plus there should be a volume to the socket. Orbital growth, facial growth. Here you see a case of a total complete cryptophthalmos on the right side. The broad defect is seen, lids are absent, and cystic eye. Evisceration of the cystic eye done. In this case, as you can see, incision made to separate the anterior and posterior lamella. An acrylic ball implant was placed in the socket. A circumcision was done for this child who had phimosis. The preputial graft was used to line the socket after evisceration of the cystic eye. Release of tarsography, lid lengthening done using post-auricular skin graft and a shell placed, and see the child after 3 years. Follow up for 6 years. Francois categorized cryptophthalmos into 3 groups: total, incomplete, and abortive. Abortive cryptophthalmos further classified into mild, moderate, and severe, depending on the extent of defect in the upper eyelid. Complete cryptophthalmos on the right side, socket was reconstructed with preputial graft. On the left side, congenital symblephrone was reconstructed, though the cornea was keratitized. In this patient, PR and PL were present. Partial or incomplete cryptophthalmos on the medial side of the palpebral fissure, with lateral lid structures being small. Eye is cystic, skin separated from the cornea, intact globe, amniotic membrane was placed over the cornea and bulbar surface of the globe, preputial graft to the lid, on the posterior surface. Here you see reconstruction done in a partial incomplete cryptophthalmos. The socket was reconstructed with skin graft. Acrylic orbital implant was placed. Customized shell in the socket and a follow-up of 2 years. Reconstruction of the defect is a major challenge. The main objective is to release the cornea from the semblefron, reconstruct the coloboma of the upper eyelid and form superior fornix. Cornea gets keratinized very early due to exposure. The extent of the cornea covered with semblefron adds to the scarring of the cornea. Reconstruction is undertaken at the earliest to protect cornea. The semblefron is released with the help of the cornea specialist. The bulbar surface of the globe and the denuded cornea are covered with amniotic membrane, which is held in place with a semblefron ring. Coloboma of the eyelid is reconstructed depending on its size. Medial advancement of torsoconjunctival flap in cases of mild degree coloboma. Lid switch from the lower eyelid or torsoconjunctival flap from moderate degree coloboma. For severe degree coloboma, besides torsoconjunctival and lid switch, other methods of lid reconstruction has to be planned. Invariably, the anterior lamella is found insufficient, which need skin graft. Multiple surgeries may be needed to complete the reconstruction. If the keratinized cornea is found to be beyond salvage, only a cosmetic shell is used for cosmesis. Vision has to be checked regularly. Some improvement was noticed after the lids were reconstructed. Congenital semblefron, medial of the mild grade. There is a medial coloboma with semblefron from 1 to 3 o'clock position. It is released and bulbar surface covered with amniotic membrane. Medial advancement of upper eyelid by incising along the supratarsal fold and anchoring the tarsal plate to the periosteum. Abortive coloboma on the medial side, reconstructed with a lid switch flap after division. Bilateral coloboma, reconstruction with torsoconjunctival flap and FTSG over the cover part. Congenital semblefron, moderate degree, reconstructed with tarsoconjunctival flap for posterior lamella and SSG for anterior lamella. Bilateral abortive cryptophthalmos, switch flap for reconstruction on the left side and a tarsoconjunctival flap for the right side. Bilateral cryptophthalmos. On the right side, Mustardase switch flap was used. On the left side, medial advancement. Subsequently, secondary revisions of the both sides were done. Patient received a corneal graft on the right side. Child had ichthyosis and bilateral abortive cryptophthalmos. Mustardase lid switch was done on both sides. To improve the lid height, full thickness skin graft from the groin was used. Due to the early intervention, child had acceptable vision. Congenital cryptophthalmos, cornea is keratinized. On the left side, reconstruction was done by using a tarsoconjunctival flap and FTSG for cover. To elevate the lower eyelid, cheek flap advancement was done. It was done for cosmetic purposes only. Exposed keratinized cornea and coloboma of temporal side. Forehead flap used for cover and tarsoconjunctival flap for lining. Here you can see the reconstructed eye. Severe lag ophthalmos after the reconstruction. The defect was on the medial upper eyelid. Child had bulbous nose. There was a defect of the eyebrow with scalp hair coming down. For the shortage of the upper eyelid, FTSG was placed, eyebrow reconstruction done, excision of the hair bearing area in the forehead was done. Bilateral congenital symblephrone reconstructed with tarsoconjunctival flap for posterior lamella and anterior lamella with skin graft.
The previous time when they came, I noticed it.
Cryptophthalmos is a rare congenital anomaly. Reconstruction is a real challenge. If the child is brought before the cornea gets keratinized, some vision can be preserved. The problems are anesthetizing the small babies. At Shankar Netralaya, we are fortunate to have anesthetists who are well versed in anesthetizing newborns. Depending upon the grade of cryptophthalmos, reconstruction can be rewarding. A variety of cases are presented. These are all managed by the same surgeon. Condition typically occurs in association with other congenital anomalies, the most frequent being syndactyly urogenital defects and dyscencephaly. The exact cause is not known. Suggestive causes are deficiency of vitamin A, retinoids during gestation, amniotic bands, and inflammation, genetically induced abnormality. The most likely mode of inheritance is or recessive.